the orthopedic spine surgeon.
Dear Chairman, I would like to thank the President as well for this kind of invitation. I'm going to talk about the complication risk stratification in adult deformity surgery, which is a no man's land. These are my disclosures. There's no conflict with this talk. So what is risk stratification? Is the process of separating patients' populations into high risk, low risk, and even important, rising risk groups with a view to predict the complications, prioritize our resources, and prevent complications. It's important in empowering informed choice regarding surgery because this is a combined procedure with the patient and is a useful tool in determining the appropriateness of surgical management in spinal deformity for ourselves. So the few predictive models in the market, we do use tools for risk stratification based on our personal experience, most of us. Peer review, case conferences, we participate, expert opinions, and there are some modeling based on identification of predictor variables, such as the SPORT trial, which is an online predictive tool you can look at. And they summarize all these, they summarize the basic factors that make a surgery risky or more risky. And we can categorize these factors into different categories, the patient-related factors and the surgical factors. I would highlight the patient's age and comorbidities from the patient side and the large correction of sagittal deformity that requires 3 colonostomies from the surgical factors. So we are talking about basically an iatrogenic problem, unfortunately. Major of high-risk deformity surgery is an iatrogenic problem. Is undercorrected deformity, is iatrogenic deformity from a single or 2-level surgery which was performed improperly. It's a adjacent segment disease because of pure correction of sagittal alignment. It's PJF, PJK for the same reason. It's infection. It's decision-making issues. It's wrong indications. And yes, there are patient-related factors, comorbidities, and major deformity that requires the approach, but this is the life. The problem is we should not raise the risk of these operations. So with regards to the morbidity and mortality of adult scoliosis surgery, until very recently, was underreported. Honestly, our complications are sobering and they are unsustainable from a payer perspective. The reported complication rate in the literature varies in between 10% and 88%, 86%, which is huge difference, isn't it? So we're talking about implant failure, requiring revision within 3 months after our first operation. We're talking about wound infections that can give you morbidity, basically, in this patient's group. We're talking about incidental durotomies, which is usually not a big problem, but poor management can make it a big problem. Neuro complications, we'll come to that. Stroke, DVT, PE, blindness, pneumonia, and death. Okay. And as I've said, it's underreported as yet. And the first report I could find in the literature was basically back in 2011, based on the SRS published, the SRS data. And the overall complication rate was roughly at the region of 10% only. But the most important complication reported being the incidental durotomy. Okay. And then the Scully risk study, the Scully 1, came in 2016, which was a proper prospective multicenter study. That shows that the neurological complication rate at discharge was 1 out of 4 patients, 25%. And 1 out of 10, they had a neurological deficit, a deterioration following surgery, 6 months post-operatively, which is significant, quite significant. I don't think we ever talked about this complication with our patients back in 2015, let's say. And then more studies, proper studies like this one, published in JNS, has reported I believe the true incidence of complications. Roughly 70% of the patients undergoing surgery do have a major complication. So we need to establish reasonable and accurate standards for our complications in this type of surgery, because people need to know what they buy and how much they pay for. How much you pay for a certain outcome is measured by the quality. There is no other method that is validated nowadays. And it's easy for you to have a look on what quality is about. I'm not going to speak any further about it. However, there is a major advantage we do have in treating these patients. Surgery is the only thing that works. And only surgery can provide a better quality of life in these patients. However, it's very expensive. It has to last at least for 10 years without a revision to worth it. So should we do this type of surgery? Yes, but we need to be a little bit better with our complications and the risk management of these patients. So certainly we need to establish some strategies, pre-op, intra-op, and post-op, to try and maximize our effectiveness. First of all, I would like to drop your attention on the osteoporosis. Don't leave the osteoporosis untreated prior to surgery. Use teriparatide. It's easy to get a teriparatide treatment, even in Greece. Do that, and this will improve a lot the biomechanics of your construct. BMI, I mean, it's not acceptable to go for an above 35 BMI correction, and smoking cessation is another big issue. We don't respect that much here in Greece, but I think is a major fail if we insist on doing surgery in people that smoke this kind of surgery. And then we have to spend a little time thinking about the surgery preoperatively. We need to assess the pulmonary function, cardiac function, and everything that can be optimized. We need to get the special equipment that we think we need to get the best result. We need to stage our operation if it is too big to for the patient we plan to do. And yes, we may have to get a second surgeon. There is no ego here. I'll show you how better results you get with a second consultant surgeon on board. So MDT is mandatory in this type of surgery. You need to organize an MDT with other colleagues. The best is to have neurosurgeon, deformity anesthetist, rehab consultants, and intensivists. And the psychiatrist, ideally, should hold a red card as well and give you a no-go. And if you do all this, and with the help of God, you go for the best result. And the reason to go for a MDT discussion prior to do this type of surgery is because our big ego, the no-go rates are pretty low, but when it comes to an MDT discussion, the no-go rates raise up, and this is of the patient's benefit usually because it improves the complication rates. So intraoperatively, we all know about the protocols of blood conservation, the fluid management, the use of TXA. I'm not going to go through in details on that. Neuromonitoring, as you said previously, somebody said previously, we need to have a clear algorithm for positive change and not spin around ourselves when something happens. Surgical techniques, I talked about 2 consultant surgeons, the protocol of staging.